Interventions to improve symptoms and quality of life of patients with fibrotic ILD, a systematic review of the literature. Patients with interstitial lung disease have a wide range of diagnoses and prognoses. The patients we are interested in are those with progressive idiopathic fibrotic interstitial lung disease. Many patients with PIF-ILD can live for many years with their diagnosis, and some are responsive to treatment. However, a subset of patients with progressive idiopathic fibrotic interstitial lung disease, such as idiopathic pulmonary fibrosis or IPF, have a short disease trajectory and a similar prognosis to lung cancer patients. Only a minority of patients are suitable for lung transplantation, and no other treatments apart from pirfenidone have been shown to influence mortality. Evidence-based palliation is seldom applied despite the high symptom burden and poor quality of life these patients experience. But what is the evidence for interventions to improve symptoms and quality of life in this group of patients? The aim of this systematic review was to evaluate the evidence for the use of interventions to improve symptoms and quality of life, the use of symptom scales for dyspnea, other symptoms and quality of life, and the evidence for the cost-effectiveness of interventions to improve symptoms and quality of life. The methods employed were initially a search strategy was conducted of 11 electronic databases from 1966 to December 2010. In addition, hand searching of 3 key respiratory journals, the THORAX, American Journal of Respiratory and Critical Care Medicine, and CHEST, were conducted for the last 3 years, with reference lists of all included papers searched. Study authors were contacted to obtain full reports where abstracts only were available or further information was required. No language restrictions were imposed, and translations of papers were performed where needed. The study population included the IPF, the NSIP, the CFA and the IIP group of patients. All stages of disease were included, and mixed groups were included where data could be extracted for the groups that we were interested in. The types of intervention included were any single or combined intervention, any pharmacological and non-pharmacological intervention, but lung transplantation was excluded. Types of outcome we were interested in were dyspnea at rest, all other symptoms, quality of life, 6-minute walk distance and economic data. The types of studies included were all trials, abstracts were included, paediatric patients were excluded, and if a trial consisted of less than 5 patients, those studies were excluded. For data extraction, 1 author, SB, screened all titles and abstracts. 2 authors, SB and JAR, extracted the data from all the full papers identified by SB. Disagreements for all papers were resolved by iteration and consensus, and data was collected which included study design, subject characteristics and study results. For data analysis, data was combined using the fixed or random effects meta-analysis. Results were presented as pooled mean differences between intervention and placebo groups with 95% confidence intervals, and for single studies the effect size and 95% confidence interval were calculated. For the fixed or random effects meta-analysis, the choice of model was determined by the degree of heterogeneity as judged by the I2 statistic and p-value for the chi-squared test. A random effects model was used if the p-value was less than 0.1 and or the I-squared value was greater than 50%. Overall, 11,407 papers were identified through the electronic search. 18 additional papers were identified through hand searching, and 2 additional papers were identified through the project advisory group and experts. There was 11,197 papers after removing duplicates, and subsequently 11,197 papers were screened on title alone. After that, 1,902 papers were excluded and 2,295 abstracts were reviewed, following which 1,937 papers were excluded, leaving 358 full texts to be reviewed. On reviewing the full texts identified, 75 papers were jointly extracted, of which 41 were excluded and listed as potentially relevant, and 34 papers were included in analysis. Of the 34 papers included, these reported 35 studies. 2 papers each contained 2 studies, and 1 study was reported in 2 papers. No health economic papers were identified. 17 pharmacological and 2 non-drug interventions were included. Overall, 3,727 patients with a range of 6 to 826 were included in all studies. 26 studies used the ATS/ERS diagnostic criteria. 17 RCTs with an average JADAD score of 4 with a range of 2 to 5 were included, and most of the placebo-controlled RCTs, most were placebo-controlled RCTs with few comparisons across classes. Interestingly enough, the majority of studies that were funded by industry or industry and other. Very few studies were funded by government. This intervention that we looked at was interferon gamma 1b, which looked at 3 RCTs with a total of 908 patients. It showed no significant effect on the 6-minute walk distance, dyspnea and cough. The effect size was shown to be minus 7.45, which was non-significant at p equals 0.52. For breathlessness, for interferon gamma, the effect size was 0.05, which was insignificant at a p-value of 0.97. Second intervention looked at was sildenafil. Sildenafil was trialled in 4 studies. 2 RCTs with 1 RCT which was followed by an open label study and an uncontrolled quasi-experimental study. A total of 378 patients were used in analysis. Collard et al. Found for 6-minute walk distance, they found a significant mean of 90% confidence interval improvement in 6-minute walk distance of 49 metres. 11 patients were used in the analysis. However, meta-analysis of data from the 2 larger RCTs did not support this finding and showed an effect size of 5.25, which was non-significant at p equals 0.467. For dyspnea, Zisman et al. Showed less deterioration in dyspnea in the intervention group, but overall benefit was not supported by meta-analysis, with an effect size of minus 0.34 and a p-value of 0.157. For pulmonary rehabilitation, there were 6 studies. These included 2 RCTs and 4 quasi-experimental open-label studies, of which 2 had controls. A total of 194 patients were used in analysis. Meta-analysis of the 6-minute walk distance showed an overall significant benefit of pulmonary rehabilitation on 6-minute walk distance. This was also supported by the other non-randomised studies. Pulmonary rehabilitation showed an effect size of 27.4 metres at a p-value of 0.021. Slide 23 shows a comparison of each of the interventions and a summary of the results for each of the pharmacological and non-pharmacological interventions, which can be read in greater detail. In addition, we looked at the outcome measures which were used in the systematic review. As you can see on slide 25, for symptom control were a great deal of different outcome measures used. For instance, for dyspnea, there were 11 different outcome measures used, and there didn't appear to be any uniformity of which outcome measure should be used. In addition, for quality of life, there were a wide range of outcome measures that had been used. So, in our discussion, we talk about the fact that there is a paucity of randomised controlled trials of interventions in this group of patients to improve symptom control and quality of life, that very few studies were powered for quality of life or symptoms as the primary outcome, that there is poor reporting of the data, that there's poor use of validated outcome measures, there's a heterogeneity of measures used and no uniformity, and government spending for funding of the studies was the minority, and there did not appear to be any economic analysis in the literature. So in conclusion, there appears to be strong evidence for the use of pulmonary rehabilitation to improve 6-minute walk distance. There is moderate evidence for sildenafil and pulmonary rehabilitation to improve quality of life. The evidence for pulmonary rehabilitation improving dyspnea is mixed. There is weak evidence for the other interventions and warrants further investigation, especially for oxygen, prednisolone, diamorphine, D-penicillamine, colchicine, interferon alpha, thalidomide and doxycyclazine. Future recommendations for research we'd like to make include consensus on the use of validated outcome scales, primary endpoints related to symptom control and quality of life, and economic evaluation of interventions.